Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional, anywhere in the world, involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it.
Hello, I'm Duke Cameron, and it's my great pleasure, along with my co-chair, Dr. Catherine Francois, to welcome you to the World University for Pediatric and Congenital Heart Surgery, the 18th educational webinar. Dr. Niwa unfortunately cannot co-chair with us today and sends his apologies. Also, Dr. Shunji Sano could not participate, but will be presenting in our second aortic webinar, which is scheduled for July 23rd. More information on that to follow. During this 2.5-hour session, we are honored to have an expert international faculty who will discuss important topics related to the management and surgery of aneurysmal disease. Please take a moment to note that there are no conflict disclosures for this webinar. The first presentation on aneurysmal aortic disease in the young will be given by Dr. Hal Dietz and is also our keynote address. His presentation and the subsequent ones will all be followed by 5 to 6 minutes that are reserved for questions from the audience. To maximize everyone's learning enjoyment of the educational material, the audience computer microphones will be muted. However, we encourage you to ask questions through your chat function on Zoom. To submit a question, open the chat function and select direct message to Catherine Francois. Type in your question and press the enter key on your keyboard. You may also submit questions via the general chat function. Also, please note that the program is recorded and will be available on the World University website within a couple of weeks. So let's get started with our program. The first talk will be delivered by Dr. Hal Dietz of Baltimore, Maryland. The topic is aneurysmal aortic disease in the young, pathogenesis, natural history, and medical therapy.
Thank you, Duke. I'm sharing my screen. Can everyone see the slides?
Looks good.
Looks good.
Perfect. Thank you.
All right, well, it's really a pleasure to join everyone today. The topic for my talk is kind of broad for this time slot, but I'm going to try to bring folks up to date on what we've learned about the mechanism of aneurysmal disease in the young, how the different conditions compare to each other, and a few insights on current and what I view as the future of medical therapy. So over the past 15 years or so, our knowledge about the cause of aortic aneurysm, especially thoracic aortic aneurysm, has really evolved quickly. In general, there are three broad categories of genes and proteins that have proven to be underlying this condition. They can be broadly binned into the categories extracellular matrix, TGF-beta signaling, and genes and proteins that regulate vascular smooth muscle cell contraction. In general terms, diseases caused by defects in the extracellular matrix cause syndromic presentations of arterial aneurysms. Those involving the TGF-beta signaling cascade typically cause root aneurysms, also with the potential involvement of other arteries, and again, syndromic presentations. And mutations that affect the smooth muscle contractile apparatus, by and large, tend to cause non-syndromic aortic aneurysms and dissections that typically occur a bit later in life. Today, I'm going to focus on the syndromic childhood presentations of aortic aneurysm, with a focus on those caused by alterations in the TGF-beta signaling cascade. And a nice example is Marphan syndrome, which is a disorder that affects about 1 in 5 to 10,000 people worldwide. The cardinal features involve the eye, such as dislocation of the lens, the skeleton, such as overgrowth of the long bones, but most importantly, a strong predisposition for aortic aneurysm at the sinuses of Valsalva that in general will tear or rupture if left untreated. We were able to show back now over 30 years that Marphan syndrome is caused by gene changes in the gene that encodes the protein fibrillin-1. Fibrillin-1 participates in the formation of the extracellular matrix. It acts as a scaffold to build elastic fibers in tissues like the vasculature, the lung, and the skin. But a simple weak tissues model didn't adequately explain many of the features of Marphan syndrome, such as overgrowth of the bones or the craniofacial manifestations of the disorder. So over the course of about 10 years, our lab and others contributed to the knowledge that microfibrils that are composed of fibrillin-1 serve a second important function in that they interact with and regulate the activity of a large class of growth factors called TGF-beta. In the presence of deficient microfibrils, as in Marphan syndrome, we observe excessive activation and activity of TGF-beta in the proximal aorta by mechanisms that are still not fully understood. Over the course of the last decade or so, again, we and others have participated in the definition of an axis for aortic disease, a large series of molecular events that appear to contribute to or drive the progressive enlargement and risk of tear of the aorta, including TGF-beta, but also including things like the angiotensin II receptor, the oxytocin receptor. Ultimately, all of this collapses on a common signaling cascade that ultimately activates a molecule called PKC and subsequently ERK. Those are important because I think they're defining new opportunities for therapeutic intervention that we'll discuss more in a moment. Now, based upon this knowledge, there was an early hypothesis that blockade of the angiotensin II type 1 receptor with medications such as losartan might be able to suppress abnormal aortic growth by decreasing the production of TGF-beta ligands, receptors, and activators such as thrombospondin-1. We went on to do a clinical trial in mice with Marphan syndrome, and showed that compared to placebo-treated animals, mice treated with beta adrenergic receptor blockers, such as propranolol, that lower blood pressure but do not address TGF-beta, led to a relative but significant reduction in aortic root growth rate, but had no influence on aortic wall architecture with ongoing high TGF-beta signaling activity. In contrast, Marphan mice treated with ARBs, such as losartan, showed full normalization of aortic growth and preservation of aortic wall architecture. Now, there have been many trials of both beta blockers and angiotensin receptor blockers in Marphan syndrome since that time. Those designs of the studies have been different, and the early results were somewhat ambiguous, with some studies showing a strong protective effect of ARBs such as losartan, others showing that losartan was as good as beta blockers, but not superior to beta blockers. Recently, a very large, well-controlled meta-analysis was reported, including data from 7 prospective trials and over 1,500 patients. This study demonstrated that ARB-treated individuals, largely children and young adults, showed slower aortic root and ascending aortic growth when compared to placebo, no other treatment. And in combination with beta blockers, the addition of losartan led to a dramatic suppression of aortic root growth rate when compared to beta blockers alone. Another important observation came from a group from the Netherlands who did a long-term follow-up of their patients that were either treated with prior medical therapy or losartan. They observed that the benefit from losartan was sustained over time, now getting out 9 years from initiation of treatment. But perhaps more importantly, they showed that the use of ARBs caused a significant reduction in important clinical endpoints, including operation at the aortic root, operation beyond the aortic root, aortic dissection, and all-cause mortality. Now, a number of years ago, my colleague Bart Loeys and I recognized and described a new aortic aneurysm syndrome that had many features in common with Marphan syndrome, but also the potential for unique craniofacial features such as widely spaced eyes or a cleft uvula in the back of the throat. Importantly, these children tend to have a very diffuse and somewhat aggressive aortic condition that causes aneurysms not just at the aortic root, but at many other predictable sites throughout the circulation. This condition is now referred to as Loeys-Dietz syndrome. Now, based upon what we had learned about Marphan syndrome, it was reasoned that Loeys-Dietz syndrome would also likely relate to altered TGF-beta signaling. And many groups now have shown that different presentations of Loeys-Dietz syndrome are caused by gene changes in genes that encode effectors of the TGF-beta signaling cascade. A related phenotype, again, with all the craniofacial, skeletal, and cardiovascular manifestations seen in Loeys-Dietz syndrome, there's this other condition called Sprinson-Goldberg syndrome, has the added feature of highly penetrant developmental disability. And we were able to show that this is caused by mutations in a molecule called SCI that serves to suppress the TGF-beta gene response. So we went on to make mouse models of Loeys-Dietz syndrome. As we had seen in Marphan syndrome, there's an obvious signature for increased TGF-beta signaling in the aortic root of these mice, the most vulnerable segment. Elena Gallo was able to show that losartan was as effective as we had hoped and as seen in Marphan syndrome in Loeys-Dietz mice. And in this context, beta blockers did not afford significant protection. Use of losartan also normalized aortic wall architecture, where this was not observed with beta blocker therapy. Now, Ben Kang went on to make mouse models of Sprintzen-Goldberg syndrome. As we had hoped, the use of angiotensin receptor blockers was dramatically effective at suppressing aortic root growth and preserving aortic wall architecture. So the theme that's coming together is these data suggest a broadly relevant mechanism, that is alterations in TGF-beta activity and treatment strategy in syndromic presentations of thoracic aortic aneurysm. I think it's fair to say that we have two therapies, that is ARBs and beta blockers, that show evidence of some protective effect. But I also think it's fair to say that there is room for improvement in medical therapies. Now, based upon these and other considerations, there are emerging treatment principles for these different syndromic aneurysm conditions. In Sprintzen-Goldberg syndrome, there's relatively low incidence and severity of vascular disease, tends to focus at the aortic root. So it's suggested to image intermittently and reserve medical management unless specifically indicated for that individual. Marphan syndrome shows a high incidence of aortic root aneurysm. They tend to follow the rules with dissections largely when the dimension exceeds 5 centimeters. Here we echo yearly or more, or perhaps even more frequently, and initiate medical therapy early in life. We image the entire aorta in adulthood or after aortic root surgery. Now, in Loeys-Dietz syndrome, we can see more aggressive aneurysms. There is a spectrum of disease severity, both within a class, within a group of patients with the same underlying gene, and certainly between the different gene categories. On average, in our experience, the patients that have changes in the TGF-BR1 or 2 gene are more severe than those with SMAD3 mutations and so forth. But it should be stressed that these are broad guidelines, and you need to make observations for individual patients to realize the potential of their underlying disease to cause problems earlier in life. Root surgery should occur less than about 4.5 centimeters in all types, but it's often desirable to use a threshold of 4 centimeters, especially in people with Loeys-Dietz syndrome type 1 or 2 caused by mutations in the receptor subunits, because we and others have seen a incidence of tear or rupture with measurements at or even slightly below 4 centimeters at some regularity. In this condition, we use medications aggressively and use widespread MRA or, if necessary, CTA imaging about every 2 years to assess the entire arterial tree. There are lessons to be learned about the specific genes and even specific gene changes. For example, one gene change that we've studied occurs in the TGF-BR2 gene. Turns out to be the most common mutation causing Loeys-Dietz syndrome, and also the most severe mutation causing Loeys-Dietz syndrome. We've seen about 19 unrelated people with this DNA change. All had initial root surgery very early in childhood, all required a second surgery, often for ascending aortic or subclavian aneurysm, pseudoaneurysm, or dissection. Half have required a third vascular surgery, many a fourth, and a third have died during childhood, most often due to type B dissection. The oldest living patient with this mutation is 19 years. Here you can see the rapid evolution of disease in one of our patients at age 11, had a scan that showed obvious arterial tortuosity, but no aneurysms in the head and neck. But 1 year later, without any symptoms, had shown the emergence of a giant subclavian artery aneurysm. Another connective tissue disorder that has caught our interest is vascular Ehlers-Danlos syndrome. This is caused by mutations in type 3 collagen. Unlike Marphan or Loeys-Dietz syndromes, in vascular Ehlers-Danlos syndrome, vascular disease, including aneurysm, can involve any muscular artery throughout the body. And in fact, the aortic root is typically spared in this condition. Tear or rupture of an artery often occurs without any prior enlargement, making monitoring of this condition very difficult. There's also a risk of rupture of the large intestine and pregnant uterus. This is a condition that's difficult to manage surgically because of the fragility of the tissues and the frequency of surgical complications. So we went on to make mice with vascular Ehlers-Danlos syndrome, both with a mild mutation and also a severe mutation that had previously been observed in multiple patients with this condition. With the severe mutation, we're going to focus on that. You can see that about half the mice had died from aortic rupture by about 40 days of age. So really a very aggressive presentation in this mouse model. Specifically, when we had this mutation on a certain mouse background called the Black 6 background. It's just a typical mouse strain that's used in medical research. We were startled to see that if we put this same severe mutation onto a different experimental mouse background, nothing special about it, we saw that vascular EDS mice, again with this catastrophic mutation, lived a full normal mouse lifespan despite exercise, despite pregnancy, despite stress. So this really taught us that nature has developed a strategy to beat this disease, and our incentive was to try to learn nature's secret with the hope that it could be mimicked with the use of medications. So genetic tests were performed that allowed us to map the modifier gene to a specific mouse chromosome and even a specific mouse gene that we call MAP2K6. The name of the gene isn't important, but the important result was that in the protected background, a sequence of events downstream of this MAP2K6 gene ultimately led to suppression of both PKC and ERK activation. So the same end players that we had observed in Marphan syndrome. We now again have a complex understanding of events that drive vascular disease and vascular EDS. These explain the risk during pregnancy that is induced by the hormone oxytocin in our mouse model. It explains the risk to males, and specifically adolescent males who are going through puberty based upon activity of the androgen receptor. It defines new treatment strategies, but most importantly, I think everything once again is collapsing on the PKC and ERK axis. So on this basis, a company called I2 Biopharma, I serve as a consultant for this company, has decided to launch a large multi-center, well-controlled clinical trial of a PKC inhibitor for people with vascular EDS. And we hope that this trial will begin sometime within the next few months to 6 months. So I want to end by thanking the remarkable young people that I have the privilege of working with every day and my sources of funding. And I thank you for your attention. I'd be happy to take questions.
Thank you, Dr. Dietz, for this nice overview of the syndromic aortopathies and possible medical treatments. I have one question for you. When it would be too late to start a patient on losartan with beta blockers, and what clinical targets should be used to titrate the dose of these medications?
Those are good questions. We in our mouse model looked at initiation of therapy right at birth. We then waited a little bit longer and waited till weaning of the mice, and then did studies in adulthood, and we showed that there was a benefit of ARBs in all age groups. That has been explored in people with Marfan syndrome. For example, the study in the Netherlands was largely focused on adults with Marfan syndrome, where they were able to show a protective effect of ARBs when added on top of beta blockers. They did not assess the ARBs alone in that study. They also were able to show something that I found very informative. If in patients that had already had aortic root surgery, in adults after their root surgery, the use of ARBs was able to suppress progressive enlargement of other aortic segments. So I think the answer is that there is a window of opportunity that extends throughout development for use of these medications. With regard to parameters that are used to titrate the medications, largely tolerance is the answer. With beta blockers, heart rate can be a useful parameter. Sometimes that's very formalized with the use of Holter monitors, but more often it's heart rate is measured after brief submaximal exercise, with a goal of keeping the rate less than about 100 after exercise. With ARBs, again, it's largely a tolerance issue. Fortunately, while ARBs are good medications at lowering blood pressure, they don't tend to have much of an effect on a normal blood pressure. So generally, tolerance is very good for even with high dose ARBs.
Okay, thank you very much. In the interest of time, I think we should go to the next speaker.
Then I will share my screen.
Thank you. The next speaker is Dr. Shaine Morris from Houston, who will be speaking on the genetic basis of aortic disease and the role of genetic testing. Dr. Morris.
Yes, thank you so much, Dr. Cameron. And I really appreciate the ability to be here today and on such an esteemed panel. I am going to be talking mostly about the role of genetic testing in these patients, as Dr. Dietz beautifully explored more the genetic basis of aortic disease. So I am part of the scientific advisory board for the A2 Bioscience clinical trial. That's my only disclosure. So the objectives of this are to understand the scope of genetic testing in contemporary times in pediatric and congenital aortopathy, and to understand how genetic testing can alter management. I think this has been a dramatic change in the past decade, and so we're going to go over a little bit of it. So just to put it in a clinical context, I want to demonstrate why this is important. So many of us, whether you're a surgeon or a cardiologist, might be faced with this situation. A new patient comes in, we'll say a 13-year-old patient, referred, and you see this echo, and you see that there's aortic dilation. And you get the measurement back on echocardiography, and it says the root diameter is 4.3 centimeters. So we're in a difficult situation. Here are the clinical questions. What is this patient's risk of dissection, right? That is going to really modify what our treatment strategy is. Is medical therapy indicated? Do we think we need to give medical therapy? Is surgery indicated? And if so, now, in the future, when? And can genetic testing help with these decisions? And I would say, absolutely. Now, our goal is to prevent aortic dissection. And unfortunately, this is a patient of ours that dissected about 10 years ago, a 15-year-old with Loeys type 2 due to TGFBR2 mutation. And I would say our goal is to stop that from happening. So what influences our treatment decisions? I will say in a prior era, you sort of would look at a patient, look at them clinically and say, do I think this is Marfan syndrome or not? And if it was Marfan syndrome, maybe you'd get genetic testing, but probably not. It was really expensive. It was a hassle. And I think many clinics still don't test for Marfan syndrome. And basically, if they look syndromic, if they had at least moderate dilation, maybe we'd start medication. And in the current era, what's really amazing, and how I mentioned this partly, is the gene really determines risk. So, oh, my slides got held up. Oh, sorry. Okay, so just to show you some examples. So these are 3 of my patients, and you can see that each of them have some aortic tortuosity. They have aneurysms in different places. The first patient has significant aortic root dilation, as well as diffuse dilation of the ascending aorta and proximal arch. The second patient has predominantly an aneurysm of the ascending aorta, and the third one has diffuse dilation and sort of this extreme elongation of the aorta. Well, if we look, the first patient has Marphan syndrome due to an FBN1 variant. The second patient has a Notch1 variant which is associated with bicuspid aortic valve. And the last one has 22q11.2 deletion syndrome with tetralogy of low pulmonary atresia. Now, they all have overlap in their actual anatomic phenotype, but we would treat these patients dramatically differently based on their genetic diagnosis. Just to show you a few more, again, this first one has an ascending aortic aneurysm. The second one has a bicuspid aortic valve, tortuosity, and elongated vessel. Second has diffuse dilation. The third one, this is a patient that came to us with a dissection. You can see these are 4 different mechanisms of disease. The first one has a filament A deficiency. The second one has arterial tortuosity syndrome. The third one has an ACTA2 variant, which is one of the non-syndromic conditions. And the fourth one has a TGFB2 pathogenic variant causing, in this patient, Loeys Dietz type 4. So what are the gene defects associated with aortopathy? So as Dr. Dietz mentioned, they come in 3 major groups. So ones that affect the extracellular matrix, ones that affect TGF-beta signaling, and ones that affect vascular smooth muscle contraction and or the cytoskeleton. There's also these other kind of aortopathy groups that are separate that seem to be different mechanisms, including Turner syndrome, which is monosomy X. And of course, this dilation we see in congenital heart disease, and also these other conditions like Notch1, FLT4, which cause non-syndromic aortic dilation, and 22q11 deletion syndrome, in which you can have aortic dilation in the absence of congenital heart disease. And what do we do about these conditions? So, we are still learning a lot, but in general, this sort of goes over risk of dissection or rupture by the genetic diagnosis. So as Dr. Dietz mentioned, in vascular, Ehlers-Danlos syndrome and Loeys Dietz syndrome types 1 and 2 due to variants in TGFBR1 and 2, the risk of dissection is fairly high. These patients need more aggressive treatment. In Marphan syndrome and in SMAD3, TGF-beta2, TGF-beta3 variants that can cause an overlapping syndromic appearance that overlaps with Loeys Dietz and Marphan syndrome and occasionally non-syndromic, they do have a risk of dissection, but as mentioned previously, it is probably less than those first 2 groups. If you look at Turner syndrome and isolated bicuspid aortic valves, certainly we know these patients have an increased risk of dissection above the population, but this has almost never been reported in children and is still uncommon. And if we look at these conditions, filament A, congenital heart disease, 22q11 deletion syndrome, and arterial tortuosity syndrome, there are rare reported cases, except in ATS, but do we need to be as aggressive in these patients? It's still unknown. I'll just go back. I know these are getting revised shortly, but these are the current guidelines for treatment. And I'll just summarize basically for TGFBR1, TGFBR2, 4.4 centimeters is written in these guidelines. As Dr. Dietz mentioned, sometimes people do go down to 4 centimeters. In Marphan syndrome, 5 centimeters, isolated bicuspid valve, 5.5, and in Turner syndrome, 2.5 centimeters per meter squared. So this is what's published, but the subtlety in genetic testing has gotten much more complicated than this. And I haven't seen the new aortic guidelines. I think they're about to be printed, but we'll see if there's more subtleties incorporated. So if there's not a risk of dissection, for example, in these patients, I do think there is a significant risk in filament A that's under-recognized, but especially in these other 3 conditions, is medication warranted? So, and clear if not, most people in congenital heart disease won't treat the aortic dilation unless it's severe. So additionally, making genetic diagnosis affects surgical timing. So, it used to be really hard to do testing, but now for those of you that don't do this all the time, it's really easy. These are just some examples of some commercial labs. So we used to draw a blood sample, wait 4 months. It would be an exorbitant cost. But now all of these companies and several other companies, and these are just US companies, you can do a buccal swab or a saliva sample the same day you see the patient in clinic. They assist with insurance, and usually it's max out of pocket of $250 It's $100 often. And if you have insurance, it's mostly complimentary and it comes back in about 3 weeks. So it's so much easier. It can really help affect your timing. So again, it used to be prohibitive. Now it's much easier. Now, the one thing to think about is I'm talking about an aortopathy panel, which would look for the conditions that Dr. Dietz and I talked about, the smooth muscle contraction variants, TGF-beta variants, and extracellular matrix variants. There's also, if you think it's Turner syndrome, you have to order a karyotype. That's a different test. So just going to go through some detailed diagnosis. So some examples. So if a patient is transferred to you with a diagnosis and someone thinks, well, this could be Marphan syndrome, or this could be Loeys-Dietz syndrome, they look syndromic. So once you know the syndrome, does the actual genotype matter? Does the actual DNA change matter? Like, does it really matter that we know it's Marphan or Loeys-Dietz? Does it really matter that we get the sequencing, or can we just put in our clinic note, they have this syndrome? Should you list the gene and the mutation in your note when you're discussing this for other patients? Should you care? Does this detailed diagnosis matter? And I would say absolutely. So this is just an example. So these are some aortic growth charts from patients at our institution with variants in TGFBR1, TGFBR2, and TGFB2 mutations. And if you look on the left is aortic root diameter, and if you look on the right is aortic root Z-score. The patients in red have TGFBR2 variants, green is TGF-beta2, and blue is TGFBR1. And the patients with the dots, they had surgery. And you can see just by looking at this that BR2 disease is generally more aggressive. So that's important. If you know this, if you're seeing a 1-year-old or 2-year-old, to know you probably need to be more aggressive with their therapy. So this is just talking about the actual gene. I'll talk about the variant in a second. Now, if you look at these stars, what's really interesting, these are all the patients with bicuspid aortic valve. We know that bicuspid aortic valve is more prevalent in Loeys-Dietz, but if you look at this, patients with bicuspid valve had much more aggressive courses, had much more early surgery. And so this can be diagnosed on the very first echo. So if you have a patient with a TGFBR2 variant and bicuspid aortic valve, you know you need to be especially aggressive and let this family know that they might need very early surgery. So this is a study coming out of the Montreal Aortic Consortium. This is looking at actual variants within BR1 and BR2. This is just an example, and this is an example that Dr. Dietz alluded to. This is looking at survival curves for freedom from event with TGFBR2 to an arginine 528 on the left and arginine 460 on the right. And you can see that this is that variant versus other. You can see that this TGFBR2 528 variant is extremely aggressive, and almost everyone in the sample has had an event by age 20. I just had my first patient meet age 20, so I'm very excited that we have 7 of those patients, but they are very scary. But you can see that this TGFBR2 arginine 460 variant is much more mild, and this really can affect prognosis in these patients. This is looking at variants from a different perspective. This is a paper, as ancillary study from the Pediatric Heart Network. This is looking at variants and response to medication in Marphan syndrome and response to atenolol and losartan. And if you had these certain variants in genes, and these are not really pathogenic variants, but variants in response to medications, the response to atenolol was lower if you had this one variant than in groups that did not have it, or sorry, was better. So they had faster decrease in the aortic Z-score. So again, the variations do matter. This is talking about vascular Ehlers-Danlos syndrome. We've known about the genotype-phenotype correlation for VEDS much longer than the other conditions, but we know that patients that have a splice site variant or a glycine substitution have much more aggressive disease. This is survival curves than patients that have a null or haploinsufficient variant. So on the left is the variant type. On the right, these are all the glycine substitutions. And just based on the size of the protein that's replacing the glycine, you can have more aggressive or less aggressive disease. So it really does matter. This is one more example. This is an ACTA2, one of the non-syndromic variants. I'm really sensitive to this because we've now had 3 young men dissect with ACTA2, totally non-syndromic, non-diagnosed, and 2 of them passed away. And this is a really hard diagnosis to make. They do have aortic dilation, but they have no other syndromic features. But you can see that this arginine 179, if you look on this Kaplan-Meier, has a very early event rate versus the 258. Half of them have had an event in their early 30s, but is less aggressive. So overall, and not to go over this in detail, but basically the variant, the gene affected does matter and the variant matters. So I think we just need to be in a new era where I know in genetics clinics, people are writing this down, and some cardiology clinics, but as cardiology and cardiac surgery providers, we really need to focus more on the diagnosis, the variant, and how this can affect our patients. So in summary, aortopathy genetics have dramatically changed in the last decade. Genetic testing is a standard of care to identify the affected gene, and it heavily guides management. And rapidly, the specific variant can help guide management as well. Thank you very much. And also just wanted to thank the teams that I work with and our funders and supporters.
Thank you, Dr. Morris, for this very clear talk and clear message. For the moment, there are no chat questions, but I have a small practical question. If we as surgeons operate on a patient with a known genetic testing, is it still useful to obtain aortic samples of the wall, or does it not add anything to the diagnosis?
Well, I think we're still understanding the modifiers within all of these conditions. That's a huge area we don't understand, why people in the same family, some have more aggressive disease than others. And I think at least banking these samples can definitely help in the future. I don't know if you already know the variant, if you already know what the gene is in that moment or that day is going to make a difference, but having the sample bank, I think, could be quite important. And especially if you don't know, one of our young men that just passed away at a massive type A dissection, non-syndromic, the pathologist the same evening while the patient was in the operating room called me and said, oh my gosh, this is not Marphan syndrome. There's smooth muscle hyperplasia. I think this is ACTA 2, within 24 hours of him showing up. And we certainly didn't have the genetic testing back. And so it definitely is helpful when it's undiagnosed. And I think in the future it can be helpful in those that are diagnosed.
Okay, thank you very much. I encourage everybody to ask questions in the chat, but for the moment we have no more questions. So I think we can move to the next talk. Please, Duke.
Thank you. Our next speaker is Justin Tretter from Cleveland, Ohio. His topic is imaging modalities for patients with diseases of the aorta.
My name is Justin Tretter, and I'm the Director of Advanced Cardiac Imaging and Co-Director of the Aortic Valve Surgical Planning Center for the Congenital Program and Director of Cardiac Morphology at the Cleveland Clinic. I have the pleasure to talk about imaging modalities for patients with diseases of the aorta. I have no disclosures. Specifically, we're talking about non-inflammatory causes of aortopathies. And echo serves as the main imaging modality for following these patients with clear advantages, including great spatial and temporal resolution, but especially as we get into our older patients, common weaknesses like limited acoustic windows and the inability to accurately assess the more distal aortic vasculature. And this is where cardiac MRI and CT have their strength in the consistent spatial resolution for evaluating the thoracic aorta. And they both have their weaknesses. MRI, with depending on the program, its availability, along with contraindications related to various metallic implants and prosthesis that our patients may have. And cardiac CT, with one of the main weaknesses being radiation exposure. So this talk, we're going to specifically focus on assessing the dimensions of the thoracic aorta. For assessing valvar function, I would refer you to my talks in the aortic valvar stenosis and regurgitation webinars. So starting proximally at the virtual basal ring plane or echocardiographic annulus, it's important as we hover by 2D parasternal long axis echo, which is analogous to panels E and H, that we open up the widest part of the aortic sinuses. And it's only there that we start to get near, but not quite at the minor axis of this oval or D-shaped structure. And this is part of the reason why it's commonplace as we follow these patients with aortopathy to see these echo annulus measurements all over the place. When important, especially for surgical planning, we can use three-dimensional data sets, whether by three-dimensional echo, MRI, or CT, with multiplanar formatting to evaluate the short axis of this plane and measure a major and a minor axis. For the aortic root, it's very important to understand the various methods and how they correlate with each other. In pediatrics, it's commonplace to use an inner edge to inner edge measurement in systole. And a recent study demonstrated that when measuring using this method in systole versus diastole, there's significant differences. So very important to have consistent methods within the same echo lab, and to be very clear, especially for patients who may transition from one lab to the next. So when these patients often will go for MRI or CT for more accurate three-dimensional evaluation, there's three different methods that are used, as shown in A, D, and G. There's no normative pediatric or robust normative pediatric data. There's only normative adult data for measure in panel A and panel G. That said, panel D has been demonstrated to correlate well with echocardiography, as we're hovering somewhere between panel D to panel G. So my preference for pediatrics is to use panel D, the center of sinus to center of sinus measurement, and relate it to the echo PHN echo Z scores, again related to the lack of MRI or CT, good robust MRI CT pediatric data. And if we look at the analogous long axis images, you can appreciate, looking at the root measurements, how significantly different each of these measurements are in the same patient. So understanding Z-scores is very important. Recently, the Pediatric Heart Network, or PHN, established a relatively more robust database for our pediatric patients. And importantly, they compared to the historical Boston, Italy, and Detroit databases, showing that in each of these, the PHN Z-score for the aortic root dimensions will give you a higher Z-score for the same absolute dimension. So very important to understand, especially when comparing to established guidelines that were established prior to the PHN echo Z-score. So important going forward that we start to relate these more robust PHN echo Z-scores to our various guidelines, especially in the patient population that we're talking about today. And in this light, a group looked at how the PHN Z-scores led by Leo Lopez compared to the other Z-scores, like Dr. Colin's Boston Z-scores, showing that on average, when looking at the Z-scores, dilated Z-scores of greater than 2 to 3 or greater than 3, as shown in yellow and red, that there's more patients that will be diagnosed as having dilated aortic roots, and more patients, therefore, that will be put on medication therapy. So again, very important for us to understand this, and going forward to establish this to refined patient guidelines. Again, going back to the comparison of echo to CT and MRI, especially in our patients going for aortic root surgery, as shown in this adult study, they often have asymmetric aortic roots, whether normal trileaflet valves or even more so in functionally bicuspid valves with tricyneural roots. And on average, comparing the minimum and maximum dimensions by CT, there were about 5 millimeters on average difference. And even more so in the bicuspid aortic valve, 6 millimeters on average. And then comparing the major measurement or maximum measurement by CT to the echoperisternal long axis, it was 4 millimeters on average difference. And this becomes even more so in the functionally bicuspid valve, depending on the phenotype, shown in this study that those with right non-fusion had larger discrepancy when comparing the peristernal long axis echo to the MRI largest dimension between the sinuses, demonstrated by this figure here of the widest dimension with a solid white line compared to how we're cutting by peristernal long axis with this hash white line. Also, asymmetry of the root becomes important, as demonstrated in the prior study, with greater discrepancy in those with asymmetric aortic roots. With the rarer bileaflet and bisinuate aortic root, it makes no sense to use a trisinuate measurement. So better to measure a major and a minor axis, recognizing there's no normative data to compare that to. Just this month, a multi-center adult study demonstrated using these two-dimensional measurements that patients with both genetic-based and non-genetic-based aortopathies had type A aortic dissections at smaller dimensions for both the aortic root and the ascending aorta than guidelines would suggest for prophylactic valve-sparing aortic root replacement or addressing the ascending aorta. So this questions these two-dimensional measurements. In 2016, it was demonstrated in adults using a cross-sectional area related to height, and specifically a threshold of 10 centimeters squared per meter, correlated better to death and dissection in adult patients than standard two-dimensional measurements. And recently, a couple months ago, my group at the Cleveland Clinic demonstrated in pediatric and young adult patients that this aortic root cross-sectional area to height, as shown in the green line here, tracked better with the absolute aortic root dimension in the blue line compared to the red line of the z-scores of the aortic root as our pediatric and young adult patients grow. And more specifically, they demonstrated that a measurement of 5 to 7 centimeters squared per meter correlated with standard surgical threshold, so much lower than this 10 centimeter mark. However, recognizing that this was not correlating with dissection, but standard surgical threshold. So going forward, we need to understand in our pediatric and young adult population how this measurement correlates with dissection and poor outcomes like death, to better guide us in how these may help us better time surgical thresholds. So what's the best way forward? I definitely think this two-dimensional aortic root area correlated to height is the way forward. We need, as I mentioned, to better understand how it correlates to dissection and death, which obviously is difficult, and obviously we want to intervene before that happens. But at a minimum, we need institutional consistency. We need to report methods, timings, and for MRI, the sequence used to allow comparison within the institution, but also across institutions. We also need to understand the z-scores used and how they do or don't correlate to established guidelines. So how about the rest of the thoracic aorta, from the sinotubular junction to the ascending aorta and beyond? So echo still serves as the mainstay for these two planes. However, increasingly, MRI and CT will be used, especially in our older patients, if there's any question. And this adult study demonstrated, looking at the orange square and the green triangle, that the MRI and CT had higher measurements related to peristernal long axis echo on average for these two planes. And this relates to a couple factors, including the fact that this multi-institutional study did not have a core imaging lab. So some labs were using the recommended double oblique method that we should be measuring from three-dimensional data sets, where we get perpendicular to the wall of the structure that we're measuring, where others used a straight axial plane, where it's not necessarily perpendicular to the walls being measured. And shown here, we're getting 46 and 45 versus 44 and 44 with the more appropriate measurement. So they can have differences that may become significant. So specific to these various syndromes, Marphan syndrome, which more commonly has aortic root aneurysm involvement, echo is going to be the mainstay at diagnosis to understand progression, and then at least annually with shorter intervals if there's any concern. MRI or CT is used if there's any discrepancy or significant progression by echo, especially if approaching surgical thresholds. And if they haven't had it yet, by the time they reach adulthood, it should be obtained because of the higher incidence for more distal involvement, and especially after aortic root surgery is performed, related to the higher incidence for more distal involvement. Loeys-Dietz syndrome, because of the more diffuse involvement of the aorta and medium-sized vessel involvement, along with tortuosity of vessels, echo will follow the same guidelines, but MRI or CT from head to pelvis will then be obtained at baseline and at least every 1 to 2 years. And specifically with vessel tortuosity and specifically vertebral tortuosity, it's been shown to be prognostic, where we can measure the actual length of the tortuous vessel related to a straight line to give us the vertebral tortuosity index. And that's been demonstrated to be higher in our Loeys-Dietz population, to correlate with freedom from surgery, with better correlation when added aortic root Z-score, and also to correlate with freedom from death. So Turner syndrome, depending on the age, if 16 or less, then we pay attention to the Turner Z-score, specific Z-scores for these patients with different body habitus. And depending on the cardiac involvement and presence or absence of hypertension, will then dictate the imaging surveillance. In our older patients, we then pay attention to the aortic size index, comparing the absolute value to the body surface area, which then will help us to dictate the imaging surveillance. And in these patients, because of the high prevalence of partial anomalous pulmonary venous return and the reported incidence of missing this diagnosis by echo in this population, it's recommended to obtain a cardiac MRI or CT, if not already obtained, at least once. And our practice has been to obtain that in an MRI in our early adolescent patients when we know that they can get an MRI without sedation, if there's no clinical concern. Earlier, obviously, if clinical concern. Our bicuspid and unicuspid aortic valve patients more commonly will have ascending aortic involvement, plus or minus aortic root involvement. Unicuspid aortic valves have faster progression of that dilation and faster progression of valvar dysfunction. So echo is going to be dictated by the coincidental lesions along with the valvar dysfunction, and CT or MRI is going to be obtained if there's significant progression. MRI specifically if there's concern related to the aortic valve regurgitation and more accurate assessment of that, and LV size and function. And in our adult patients, because of the occurrence of intracranial aneurysms, a screening brain MRI or CT is recommended. So echo is the main imaging modality in these patients. CT and MRI provide more accurate assessment of the thoracic aorta and arterial vasculature when indicated. And it's very important for both the surgeons and imagers to understand the limitations of both our 2- and 3-dimensional imaging evaluation and the methods that are used for more accurate assessment and for consistent comparison. So thank you so much. I'm happy to take any questions. Thank you.
Thank you, Dr. Tretter, for this nice overview and also practically applicable, I think. There is one question in the chat. One moment. Oh, I lost my question. If normal baseline in bicuspid valve and Marphan, what is follow-up imaging timing for CT MRI? So I understand when you have a normal baseline diameter in bicuspid valve and in Marphan patients, what is the timing of next imaging, or how will you follow up these patients?
Yeah, thank you. That's a great question. And Shaine had already alluded to the fact that we can expect earlier progression of aortic dilation. And that's where a lot of my research focus has been on, is more on the hemodynamic, the structural and hemodynamic consequences of aortic valve disease. And in bicuspid aortic valves, for example, we've shown that the rotational position of the aortic root, when it's clockwise rotated from an imaging perspective, we can expect a faster progression of aortic dilation. And then you add into that the bicuspid valve, and then we know that just the resulting hemodynamics, we can expect faster progression. So if we have a patient, depending on the age, with a bicuspid valve with a diagnosis of Marphan's or Loeys-Dietz syndrome, then we would expect that we would get that initial echo, we would get an echo at 6 months, and depending on that progression would determine our serial follow-up. But if things were stable, then we would just continue on a yearly basis. If we saw some progression, we may then keep it to a 6-month follow-up. And And if we did continue to see progression, then we'd have a lower threshold to get a CT or MRI in the Marphan's patients. And as I mentioned in the Loeys Dietz patients, we're getting that at least every 1 to 2 years at MRI or CT.
Okay, thank you. That's clear. There is one more question coming in. Is the correlation between echo and CT just to use, is that okay, just to use echo for the initial follow-up in a not experienced team? So when you have correlation of echo and CT, is it okay to just follow with echo?
Yeah, if there's no significant change and there's no question on the imaging, then echo is great. And the gist of my talk was to really highlight to the surgeons to keep us imagers honest, to understand that we have to be very thorough with our two-dimensional echo imaging. We have to make sure that we're not just rushing through patients and getting that parasternal long axis image and being okay with that. We have to make sure that we're hovering and opening up the sinuses as wide as we can to get that more accurate measurement. But if there's any question on echo, or if there's significant progression and you want to confirm that and make sure that it's not just a difference in two-dimensional measurement error or different methods, then having a low threshold to get CT or MRI is good. And if you have availability of MRI, I would say MRI, but if not, then CT.
Okay, and there's a question about MRI. Is 4D flow sequence in MRI helpful for surgical strategy?
That certainly is a developing field. SCMR had a great webinar recently where Stanford and CHOP has shown what they're doing in congenital heart disease in our pediatric patients with 4D flow, and that certainly is where the field is going. Right now, I'm not sure that we have enough comfortability with 4D flow to use some of the information from it to guide us. For example, we can see vector flow in these bicuspid, unicuspid valves, and that can predict progression of dilation, wall shear stress, and et cetera. But right now, I think we're primarily focusing on standard MRI sequences in 2D phase contrast.
Okay, and then maybe one last question. How do the measurements compare with the intraoperative ones? Do you have any data about that?
Oh, that's Dr. Cameron can weigh in what his experience has been, but yeah, I think that, as I mentioned, if they're, especially for valve annulus size, I think that's one of the big misunderstandings across the board with both imagers and surgeons, is not appreciating the anatomy of this virtual basal ring plane, and that it's not often a circular structure. It becomes more circular in systole, but it is an oval shaped structure. So to accurately surgical plan, you, just like TAVR has really led the way in that understanding. We want to get three-dimensional data sets, whether by echo, MRI, or CT, multiplanar format, and get more accurate measurements of that major, minor axis, the perimeter, the area. And if we're going to be putting in a valve prosthesis, then we're going to be changing that configuration to a circle. And there's ways that we can predict how that oval shape will now conform into a circular shape.
Okay, thank you very much. Very interesting. I think we move to the next talk. Please, Duke.
Yes, thank you. Our next speaker is Dr. Luca Vricella from Chicago, and he will be speaking on surgical interventions in genetic diseases of the aorta, indication and surgical options.
Okay, perfect. So first of all, I wanted to thank the World Society for this very kind invitation, and congratulate the World University for putting together this great curriculum really on a global scale. It is just absolutely great to see over 250 colleagues and friends from around the world join together to share knowledge. So for the next 10 minutes, I'll talk about surgical indication and options for children with connective tissue disorders that really represent a very large proportion of children who develop aortic aneurysms. So in a grander scale of pediatric patients and adult patients, greater than 20% of all thoracic aortic aneurysms have a genetic basis. So indications for intervention in children are relatively ill-defined. We're still working on it, as we've heard from the previous speakers. And this is across a broad spectrum of genetic conditions that are associated with both proximal, most frequently, and distal aortic enlargement. So absolute diameters have traditionally been the main indicator for intervention, but as we've heard, patients with aggressive genotypes can rupture even at much smaller diameters in younger age. So as Hal and Shaine mentioned, the absolute diameter data should be integrated with incremental growth, particular genotypes, genetic testing, family history, propensity for rupture in the family, and associated pathology that are other reasons that actually take us to the operating room, such as aortic regurgitation or mitral regurgitation. Now, this is redundant in many ways, but what I wanted to say is that we're pretty much now still going to the operating room based on criteria that are relatively old and adapted from the adult world. So, our, AHA and ACC and multi-society, guidelines are from 2010 and 2014 as the European guidelines. And so when you put them all together, you have increased risk that is seen in patients who have incremental growth of greater than 0.5 centimeters per year that actually, are an indicator to proceed to surgery, across the entire board of different pathologies. Now, if you look at Marphan syndromes, of course, you go at, smaller diameters. If you have family history of rupture or dissection, incremental growth that's substantial. If you're going to the OR for aortic regurgitation and mitral regurgitation or planned pregnancy, you will go at, slightly smaller diameters. If you look at, Loeys syndrome, 4.4 centimeters, I've taken a lot of patients at diameters of 4 centimeters or less, especially those with, very pronounced, vascular tortuosity, so, high vascular tortuosity index, and with pronounced facial dysmorphism, which is associated with, a higher propensity for rupture. Now, when you look at EDS type 4, our best guess is, again, 4.5 centimeters. Patients who have familiar thoracic aortic aneurysms, there's really no specific guidelines or recommendation. We sort of tend to fall almost as a default into the Marphan syndrome indications for surgery. Patients with bicuspid aortic valves, slightly higher diameters, again, family history, incremental growth, coarctation distally, and hypertension as indicators of a higher risk in these patients. But again, we're playing with, old data, old guidelines, and adaptation from the adult world. And how about the Z-score? I mean, we always get these Z-scores that are, 7, 9, and what do we do with these? So as Justin actually alluded to earlier, very interesting data from Cleveland Clinic that was just recently published, with an indexed, cross-sectional area to height, which seems to be correlating better with growth than these Z-scores. And how about small patients? That's where really we have, questions about what is the right timing of intervention. So the small patient, for example, patient with Turner syndrome, in these patients, body surface area is indexed to the diameter in these patients, and greater than 2.5, higher risk of dissection or rupture. But how about patients with infantile presentation? Those are really patients that are very puzzling to us. These patients will often not present with, diameters that really we think we're going to go to the OR for that specific reason. The most important thing in these very small patients is that aortic enlargement leads to mass effect. And also these patients do have substantial valvular regurgitation. So my advice to the colleague surgeons on the line when dealing with these very, very small patients is to address the issue at hand, to ameliorate pathophysiology in these patients, and most importantly, keep the operation relatively simple. Recently, I had a patient that was actually diagnosed as a neonate with Loeys syndrome, very large aorta, severe tortuosity. The patient actually had a pathophysiology similar of tricuspid atresia, because this large aortic, elongated aorta with a large root was pushing and obstructing the tricuspid valve. So when the patient occluded, closed off the PDA, the patient got into real trouble. And this patient also had an in utero type B aortic dissection. So what we ended up doing for this child, again, is keep the operation simple. Shorten the aorta, put an interposition graft between the root, we plicated the root, and then an interposition graft, and the patient came off bypass. So keep the operation simple. Another important thing for surgeons is that most children will present with proximal aortic disease, so mainly root enlargement. It is a very, very rare case where you will be presented, de novo with an aortic arch problem or a descending aortic problem and never have had an operation required for the aortic root. Now, what are our surgical options? First of all, the time-honored, once gold standard, the Bentall operation, and Dr. Cameron will actually talk about this later on during this webinar. Then the root remodeling technique, or Yakub or Tyron David 2. This operation clearly has an Achilles heel, which is the late dilation of the sinus remnants leading to central aortic regurgitation and need for reintervention. But it does still have a role in the surgical armamentarium when we're dealing with patients with connective tissue disorders. In particular, you're presented with a child who has a small annulus, 15 millimeters. What are your options? To do a conventional reimplantation valve-sparing root replacement will be very difficult. And if the aortic root is large and you have aortic regurgitation, doing an intervention on the valve and on the root as a Yakub is not a bad option, knowing that you're going to be back at some point to reintervene. Now, there's other procedures that I would gather into the category of root containment. One of them is the Florida sleeve, which we have used with not great success, but it's actually an operation that's been reported where the root is just contained with a graft and not really a reimplantation or a remodeling procedure. And then, of course, the reimplantation technique, which is, Tyron David 1 or 5, which is our favorite approach for patients with connective tissue disorders and aortic root enlargement. So I'm going to show you briefly a video, and I hope it plays, of a valve-sparing root replacement in a patient, a 6-year-old patient with Loeys syndrome. So this is the operative view with the large aortic aneurysm. We size to the siniotubular junction in patients with aortic valve competency. We then dissect the root very deep towards the junction. And this is the area between the pulmonary artery and the aorta. This is the aneurysm. When you go ahead and excise the sinuses, you see how thin the sinuses actually are. We also mark the coronaries to prevent torsion during reimplantation, both the left and the right. We then excise these coronaries and sort of develop them and from the root. This is the measurement of the proximal anastomosis. Then we have sutures that go below the nadir of the sinuses into the left ventricular outflow tract. This happened to be a bicuspid aortic valve with left-right fusion. Here's under the fused raphe. And then we use a Valsalva graft. We suture the bottom part of the in 3 places, 2 places in this particular case because it was a bicuspid valve. And then we reimplant the commissural post very high. And then this is followed by the internal suture line, which is the most important suture line. It is really the hemostatic line in these patients. We take our time and reimplant the sinuses within the Valsalva graft. This is a bicuspid valve, fancy intraoperative testing. Usually it's a good predictor of how the valve will look on TE. We have liberal use of these felt strips that I think actually do prevent bleeding in the first place, but also the late development of pseudoaneurysms in these patients. This is a right coronary button. Then we tuck the graft down to sort of adapt it to the usually not very large distal ascending aorta, which is normal caliber, although large, in the general population, but relatively normal for this patient. And this is the finished product. Now, when we go to the results, I just wanted to report our results with, which is probably the largest series with valve-sparing root replacement in children, 100 consecutive cases, which was presented at the ATS a few years ago. So the median follow-up on these patients was 4.7 years. Mortality was 2%. late mortality was 7%. And one of the important things in late mortality was the development of type B aortic dissection, which was very aggressive, and basically the entire descending aorta all the way to the iliacs and in these patients. The interval to mortality was nevertheless pretty late after initial valve-sparing root replacement. When we look at late reintervention, this is what we have to deal with patients who have vasculopathy that, of course, is diffuse, that have suture lines that, are at risk of late problems. So the development of pseudoaneurysms in 6 patients, again, a lot of them at a late interval of 6.6 years, and the majority of these patients actually had Loeys-Dietz syndrome. These pseudoaneurysms developed at the coronary anastomosis, at the aortomitral continuity, and then at the distal suture line. In terms of aortic valve reintervention, 9 patients required late aortic valve replacement. The 3 patients we did with a Florida sleeve were converted successfully to a valve-sparing aortic root replacement with a Tyron-David 5 procedure. Now, when we looked at need for reintervention for the aortic valve replacement, we actually saw that at 5 years, 94% of patients with a valve-sparing root replacement done with a reimplantation technique were actually, free from reintervention, whereas patients with the remodeling technique or the Yakub operation tended to have a higher risk of reintervention, and this was actually maintained with disappointing, 50% freedom from reoperation at 10 years in patients with the Yakub operation. Now, how about the aortic arch? That's also a question that we have. As we've seen, in the prior presentations, the aortic arch can develop, into an aneurysm quite rapidly in particular forms and genotypes of connective tissue disorders. One paper that I saw that actually was presented by Florian Schoenhoff, and this was his experience at Hopkins, is on adult patients. We would never actually be able to gather these data on pediatric patients, but this is 256 patients with Marphan syndrome compared to Loeys-Dietz syndrome. So how important is the genotype in determining the need for late aortic arch intervention in patients with Loeys-Dietz syndrome, so with a more aggressive, vascular genotype? And what he saw that arch intervention at the time of aortic root replacement was higher, even though very low, in patients with Loeys-Dietz syndrome at 5% versus patients with Marphan syndrome, which was less than 1%. When we look at patients with no history of aortic dissection, so not with a aortic wall that is weakened by the dissection process, patients with Loeys-Dietz syndrome, actually needed arch intervention at the same time, interval from the initial root replacement, but certainly at a higher rate. Still not very high, if you think about it. It's just still, you could quote families after my, valve-sparing root replacement and patient with Loeys-Dietz, it will be still under, 20% at a reasonable interval postoperatively. But, the risk for reintervention is actually higher for these particularly aggressive genotypes. So in conclusion, indication for surgical intervention are not perfect. We deal with old data and with data sets that are imported from our adult literature. Children will present most frequently with aortic root enlargement limited to the root, and prophylactic reimplantation techniques are effective and better, in my mind, in limiting need for valve and root reintervention in the midterm. Longitudinal follow-up is critical for determination of late aneurysm and aortic enlargement. Thank you.
Thank you, Dr. Vricella, for this nice talk. There's a question, there are several questions. How do you choose the size of the graft for the David procedure in the pediatric population? Maybe we can start with that. So, we usually in a competent valve, we will size the patient at the sinutubular junction. So we transect the aorta just above the sinutubular junction, and with calibrators that are usually aortic valve sizers, we will figure out what the internal diameter is and then add 3 to 4 millimeters and then splay the graft on the root. So it is really important to just maintain that geometry. Now, if the sinutubular junction is effaced and we do have some degree of regurgitation,
in my mind, it becomes more of an art. We see the size at which, we would have better competency. And by doing 3 stitches below, 3 stitches above, usually when we have the graft in place, we can simulate what the valve will actually need and how competent it will be. Sometimes you do need minor adjustments, such as, free edge plication to just maximize the height of the apposition of the leaflets. And I would say that, if you have to do very complicated, valve repair techniques, probably a valve replacement is better than a valve repair.
Thank you. Shaine Morris asks if you do think that the lower freedom from reoperation after Yacoub operation could be confounded by the fact that those children tend to present earlier and have more severe disease.
True, but I would, at this point in time, I would use a Yacoub operation only if I'm in a corner. So, it has a role in my mind, and in patients with diameter that is just too small, patients who have anomalous coronaries, and in patients with adult congenital heart disease, in particular, if you have patients with transposition, which the coronaries are anterior. But other than that, I think that when you think you can put in a graft of 22 or 20 or greater, then I would definitely do a valve replacement with a reimplantation technique.
A question from Justin Tretter: is there any data to support the sinus of Valsalva graft versus the straight grafts? And are there any occasions on which the Valsalva graft might present with limitations due to the particular configuration of the graft?
I think, in any operation, style and form should really, be what you try to achieve to maximize physiology. So, there's a reason why nature has, sinuses. And I think, some of the experimental data, shows that, the valves actually oppose better. There's better longevity, in simulators, when you actually have pseudosinuses, because you mimic the currents that, protect the valve from, slamming against a straight graft. Now, I have actually used straight grafts, in particular with smaller children, where I think, it's sometimes a little bit more difficult to have the remnants of the sinuses reach out to meet the bulging pseudosinuses of the Valsalva graft.
Okay. Maybe this is a question we should maybe report later, but maybe short answer. Once ascending aorta and the arch have been replaced surgically, is there for you any role for endovascular therapy in patients with Marphan syndrome and type DeBakey 3B dissection?
Okay, well, I like to think that my life stops at the left subclavian artery, but we've certainly seen, actually, in a recent presentation, the idea of putting a elephant trunk down the descending aorta, that is could be later on used in very elaborate and imaginative techniques to have to be used in the descending aorta. I think it is difficult to imagine how a stent graft has a major role in the descending aorta of a patient with connective tissue disorder.
This is a topic that Dr. Black will be addressing.
Yes, probably.
And we'll leave it all to Jim.
And then the last question, maybe in genetic conditions, are the leaflets spared any anomaly? Are the leaflets normal? And will the repair of the leaflets be lasting long enough?
So when we had, one of the things is you want to always just reproduce, what the valve looks like in a normal state when you don't have regurgitation on your preoperative echocardiogram. The things that we've seen in these patients is, yes, a high prevalence of bicuspid aortic valve. In our series as well, is actually 12%. And you just keep the anatomy as it is if the valve is competent. And we see also the incidence of fenestrations towards the apices of the commissural post. In an older patient, if there's a lot of fenestrations, maybe a valve replacement is not a bad option. Having said that, when we deal with children and the valve is competent, these fenestrations are there. We have not seen a need for increased reintervention in valves where we've observed these fenestrations, as long as the valve is competent.
Okay, thank you, Dr. Vricella, for a great talk and a nice discussion. Thank you.
Thank you
and now it's my pleasure to announce my co-chair, Dr. Hugh Cameron, who will speak about valve sparing versus Bentall operations.
I'm happy to go, but I think Dr. Jatene is next.
Okay. Excuse me. Yes, I'm too fast. Okay. So please, Duke, you can introduce Dr. Jatene. Please, sorry about that.
That's all right. I'm much more interested in hearing his talk than mine. So. Marcelo Jatene is from Sao Paulo, Brazil, and will be speaking on aortic root dilation after repair of congenital heart disease, the Ross, the arterial switch, and the Norwood procedure.
Good morning, good afternoon, everyone. I want to thank the World University for the invitation to participate in this important webinar. Our talk is about aortic root dilation after repair of congenital heart diseases. We have no disclosures, and we can consider that in this study of Dr. Neva, the aortic root dilation in complex heart diseases. The most common cases are the trilogy of Fallot, single ventricles, pulmonary atresia, stenosis, truncus, transpositions, hypoplast left-hand syndromes, Fontan operations, or pulmonary arteries with VSD and MAPCAS, and the post-op of Ross procedures. We don't have too much information considering the prevalence, but we have even few cases, but there are some information like there is an incidence of 15% in the adults with the trilogy of Fallot operated with an ascending aorta was more than 40. And in hypoplast and truncus and Fontan, we have 98, 96, and 26% of dilation of the aortic. The ascending aorta is a Z-score of more than 2. There are some variables, there are some that can affect the structure of the ascending aorta, like systemic hypertension, aging, pregnancy, some chromosomic abnormalities, some hemodynamic abnormalities, and intrinsic abnormalities of the aortic, always the main causes to dilate the aorta. In the same study, Dr. Neva observed that in 88 cases with a mean age of 32 years old, in the surgical biopsies of the aortic specimens, he had observed the media degeneration in all the patients, and especially in the bicuspid aortic valve patients, the trilogy of Fallots and transposition cases with grade 2 and 3 of media degeneration. There were in the guidelines of 2014, there were no mentions to congenital heart diseases, but in the most recent guidelines, like this one in the American College of Cardiology, we have some recommendations for the DTGA with the arterial switch operation in the management of different complications. If we consider the Fontan operations in this study of 235 cases, we observe that the aortic root and the ascending aorta tends to increase the size, tends to dilate in this study of Kim. The same happened with the Norwood operations for hypoplast, with a progressive dilation of the new aorta. And this is frequent and well known. It's associated with anatomic, hemodynamic, and the type of surgical technique that is used. In this case of our series with a comprehensive stage 2, we use almost as a routine a homograph ring to connect the pulmonary artery to the aortic arch, and this can dilate also. In this study, as an angiographic analysis of the single ventricle tri-reconstruction, we have some cases of the Norwood procedure compared with controls, and it was demonstrated some abnormalities in the arch geometry, in the increased ascending aortic dilation, and the reduced distensibility index, comparing the Norwood cases with the control cases, all aspects that can interfere in the dilation of the aorta. In the transposition cases after the Jatene operation, we have many most frequent complications, but the new aortic root dilation is considered nearly universal and associated with some degree of new aortic regurgitation. We have some factors to influence the growth and the dilation of the new aortic root, like the presence of VSD, the mismatch of the aorta and the pulmonary artery, the root distortion by the coronary transfer, and the pre-arterial switch bending. In this study of Dr. Hazelkamp, 345 patients, After a rapid increase in the first year, there is a consistent increase in the size of the annulus and the ring with a dilation observed with the years. And in this series of the Boston's children, we observed that only 35% of the patients are freed from root dilation and aortic regurgitation in a follow-up close to 20 years. But not all the dilated ascending aorta need to be replaced or reoperated. In this study, 95% of the patients with dilated aortic root after arterial switch operation are freed from reoperation. And in this study of Dr. Derani from the Mayo Clinic, he described 3 cases of aortic root replacement after the arterial switch operation. So where's the best moment? When is the best moment for the surgical repair? We might consider the anatomy, dimension, and the growth. Maybe 55 millimeters is a good limit. The growing of more than 3 millimeters per year and the Z-score over 2 are factors, are measures to be considered. They are not definitive, but they can be considered in each case, associated with symptoms and the opportunity in the surgery if you will perform operation in another site. We have different options like the Bentall, the David or the Jakub operations, or some types of aortoplasties. And in our experience, we have a series of 12 recent cases, 6 TGAs, 3 fellows of pulmonary atresia with VSDs, 2 cases of bicuspid aortic valve with aortic stenosis, and 1 post-Ross with 7 Bentall operations, 3 Tyrone David operations, 1 supracoronary graft, and 1 aortoplasty with good results in all of them. This is a case of a boy who was 19 years old with no Lecomte maneuver after correction of transposition. And we can observe that in this specific case, after the opening of the dilated ascending aorta, the valve, the coronaries are inspected, and even the valve is inspected. It was considered a good valve, adequate valve to be preserved, and this was done by a standardized operation of the Tyrone operation. And in this case specifically, the right pulmonary artery was incised because of the stenosis, and even the pulmonary trunk was augmented by 2 different grafts. After fixing the pulmonary artery, the Tyrone David operation was performed as a usual fashion. This is the aspect after the fixation of the commissures. And this is the test. And after that, the reimplant of the coronary osteons is the final aspect of the operation. This is another case of an 18-year-old boy with severe dilation of the aortic, the ascending aorta, and the pulmonary stenosis. And with a Lecomte maneuver, we can see here the Lecomte maneuver. And after the release of the ascending aorta, the valve was inspected, and it was considered not a good valve to be preserved after the usual inspection with prolapse and very degenerated, and the option was to replace the valve and perform a Bentall operation. This is the final aspect of the operation after fixation, and then the coronary implant, the transfer of the coronary, and the placement of a graft between the pulmonary trunk and the pulmonary arteries was the final aspect of the operation. So we can consider that the cases of aortic root dilation are coming slowly but consistently. It's very important to have an adequate follow-up to identify the earliest possible, and to try to follow and decide which is the best moment for all these cases of congenital heart diseases. The surgery is considered complex. You have different options, but it's usual and standardized surgery, and that requires just an usual training for the operation. Thank you very much for the opportunity.
Thank you, Dr. Jatene, for this interesting insight into complex procedures. I have for the moment two questions. One is more about when you have a prolapsing aortic valve after VSD closure, asymmetric prolapse, and a dilated aorta. Do you have particular hints how you could preserve the valve or not?
This is very unusual case to have this situation. I remember only one case of this, that we have a huge dilation of the right coronary valsalva sinus, and it was not easy to fix it. We used some techniques just to achieve the valve, because the dilation of the coronary sinus was not too big, and the result was okay. So we don't have too much experience in this specific situation, but we need to inspect each case in particular. The easiest situation is if you have the dilation of the non-coronary sinus, because you have no osteons, no buttons, no coronary buttons. It's easier, not easy, but it's easier to fix and to reduce the size. And you can go very deep in the coronary sinus, and you can decrease the size of the aorta, and using this specific technique to fix the aortic valve.
Then there's a question, more practical question. You have a 25 years old after a Ross procedure, and the pulmonary conduit needs replacement, and the aorta has 5 centimeters in diameter. What would you do with the aorta?
Of course, we need to have more information about the case, see the images, and understand when the Ross procedure was performed, and how was the evolution and the growth of the aorta, of the allograft. I think if it's a situation that that this patient was operated many years ago, and it's going very slowly, dilation of the aorta, of the new aorta, I could consider, depending on the surgery situation, not to touch the aorta. But if you have an operation that was performed a few years ago, and the growth and the dilation of the new aorta is more rapid, of course I will access the aortic valve also, and try to fix the ascending aorta, or a Bentall operation, or wherever. So it depends on each case, on the evolution, and getting more information, it's easier. But in general, if I can give only one answer to this question, yes, I would fix the ascending aorta also.
Okay, and then maybe one last question. We know in Fallot there's not many dissections described, but do you have any cutoff diameters to operate an aorta, dilated aorta in a Fallot?
You know, the cases are really coming. We have, of course, many cases of need to replacement of the pulmonary valves, and cases with 45 to 50 millimeters. My personal, we don't have too much information in the literature, and we don't have guidelines for that also. But my personal feeling is that if you have less than 50 millimeters in the Fallot, we can wait a little more. But you have more than 50, I think it's better to touch the aorta. And another possible situation that we are performing, we have done in 2 cases. It's very recent, but we are doing like an aortoplasty. We are taking like a slice of the aorta, a longitudinal slice of the aorta, and reducing the diameter, taking the slice. The slice is coming from the deepest part of the non-coronary valsalva sinus to close to the aortic cannula. So we can reduce the diameter, it is an easier operation. It depends on the structure of the aortic wall. If there is sufficient thickness for the safe stitches, it could be a good option to treat this type of situation in this limited cases.
Okay, thank you very much, Dr. Jatene, for your talk and for the answer and the discussions.
Thank you.
I have a second go. Now I introduce my co-chair, Dr. Duke Cameron, who's going to speak about valve sparing operations versus Bentall procedures. Please, Duke.
Thank you very much, Dr. Francois. It's my pleasure to talk about the Bentall operation and valve sparing, two of my most favorite operations in heart surgery. The Bentall is absolutely remarkable. It's 52 years old. We have over a half century of experience with it, and it changed the outlook for patients with aortic root disease dramatically. Many of you know this was only a case report in thorax with a couple of illustrations and a single reference, and yet it really paved the way for safe, reproducible surgery on the aortic root. The operation we do today is truly a modified Bentall. The Bentall originally was done as an inclusive procedure, inclusion technique, where the aorta was not actually transected and the coronaries were not harvested and mobilized and reimplanted. Everything was left in place, and the distal anastomosis was inclusive, and the coronaries were just sewn side to side from the aortic wall to the side of the graft. By making it an operation with full thickness anastomoses, it became much more durable, less prone to pseudoaneurysms. And this was an operation that could be done by all cardiac surgeons for a wide range of pathologies. However, that operation replaced a valve which was either normal or near normal in many young patients. And because of that, there was interest in valve sparing. But before I make that point, it's also clear that the original Bentall, which had a mechanical valve in a prosthetic tube graft, was also expanded to include biological prostheses within the Dacron graft, the so-called bio-Bentall, and even homograft root replacements and porcine root aortic root replacements are forms of Bentall. And it's something you need to be careful about when you use the word Bentall, whether you're talking about a classic Bentall with a mechanical valve and non-inclusive technique or inclusive technique, or whether it's a biological valve, because that can obviously have an impact on durability. Now, the pioneers of valve-sparing surgery, Sir Magdi Yacoub and Tyrone David, recognized that many normal or near normal aortic valves were being sacrificed in Bentalls, and that many of the complications after the Bentall related to anticoagulation or the limitations of the bioprostheses or mechanical valves. And they therefore thought that one should explore ways to preserve the valve. And as you've already heard, the original form of this, the remodeling, which was pioneered by Magdi Yacoub, placed 3 tongues of a Dacron graft on the annulus. This graft really sat on top of the valve rather than the reimplantation, which was introduced later. And in this, the graft sits entirely around the aortic valve complex. And so because of that, it would stabilize the annulus. The reimplantation was introduced really for 2 reasons. One was to stabilize the annulus because many of the patients were young and had connective tissue disorders and were prone to dilatation. But it was also a more hemostatic operation. The suture line was internal, and the blood literally pushed the valve up against the graft, and there was much less bleeding from this than with the Yacoub type. Once the reimplantation took hold, there were various prosthetic grafts that became commercially available, which reproduced the shape of the sinuses with the hope that this would in fact improve durability. But to answer one question that came up in the chat, there's still no data that the preservation of sinuses or recreation of sinuses actually has an impact on valve durability, or at least not at the 15-year mark. We'll see whether over time there is an advantage. But as a surgeon, it's nice to do a valve-sparing route with a graft that has prosthetic sinuses and fool the echocardiographer postoperatively into thinking this was a normal aortic route, which is the badge of a very successful valve-sparing route replacement. I also want to mention that there is renewed interest in the Yakub operation, but with a separate way to stabilize the nadir, or the basal ring, either with an external ring or an internal ring or a suture. This is thought perhaps to combine the best of both worlds of the stability of the annulus with the reimplantation with perhaps some of the hemodynamic advantages of a remodeling. But this is not clear what role this is going to play. Unfortunately, valve-sparing root replacement in children got a very bad reputation early on. And I think it traces back to this experience with Pascal Bohet in Paris, where he reported a small series of patients with children with root aneurysms. And they primarily had the remodeling operation and had a very disappointing early recurrence rate of severe aortic regurgitation. And in fact, a quote there from that paper said, valve-sparing remodeling surgery yields disappointing results and should probably be abandoned in the pediatric population. And I agree with that statement, but I feel even more strongly about the second statement, which was that valve-sparing reimplantation repair may achieve superior outcome, but needs further investigation. Our results with remodeling were also disappointing, and we moved very quickly to a reimplantation type in children. This paper has already been presented to you by Dr. Vricella, but this was, at least in our view, the paper that convinced the rest of us that valve sparing did have a role in children, but that it really required annular stabilization and optimally with the reimplantation operation. The 10-year mortality was 10-year survival better than 90%. And this slide, as I think Dr. Vricella showed, is the freedom reinvention was much better with the reimplantation technique versus the remodeling. So again, to be clear, if you're going to do a valve-sparing operation in a child, it will most likely be a child with a connective tissue disorder who's prone to annular dilatation, and annular stabilization is an essential part of assuring durability of these operations. And we still believe that the reimplantation is the best operation. There's a lot written on this topic, and to cover it in just a few minutes is a challenge. And I decided to share with you a meta-analysis of valve-sparing root replacement and versus the Bentall, specifically in young Marphan patients that appeared in the Annals of Cardiothoracic Surgery. This surveyed 23 studies, nearly 3,000 Marphan patients, mostly young adults, with roughly an equal number of Bentalls or composite valve grafts, CVGs, with a limited follow-up. The CVGs were at a mean follow-up of 7 years, valve sparing 5, but both groups had patients out to 20 years. What's clear from this is that these two operations can be performed with very low operative risk, 0 to 1%. But what was a little surprising was that actual survival out at 15 to 16-year mark was better with valve sparing than with the CVG patients. Now, it's easy to ascribe this to anticoagulation, which was rarely required in valve sparing and was usually the case with mechanical Bentall. But remember that some of these patients who end up getting mechanical Bentalls did so because they presented with acute dissections, acute type A dissections. And in that setting, many surgeons then and now continue to opt to a more reliable, more quickly performed operation of replacing the valve. With experience, we've learned that valve sparing can be performed in acute type A dissection, and more groups are leaning toward that even at that initial operation. But I think it would not be fair to ascribe all of the difference in survival to the operation performed rather than the patient who was receiving the operation. One of the more encouraging messages from this this meta-analysis is that the survival, freedom from reoperation was in fact better in the valve-sparing group. Now, again, part of that may be because of the number of patients having dissections who ended up getting CVGs, but to see that at nearly 20 years, valve-sparing operations in this very large meta-analysis actually had fewer reoperations is very encouraging, because we always thought that would be the problem with valve sparing, that there'd be some technical problems and late aortic regurgitation, and you would pay a higher price in terms of reoperation for a better quality of life for young people. But I think it's emerging that actually the freedom from reoperation are remarkably similar as we approach 20 years. These plots show the odds ratios for endocarditis, thromboembolism, and hemorrhage in the Bentall versus valve-sparing operations. And you can see that for almost every study in which this was examined, valve-sparing, and that when the dot appears to the left of the vertical line, that means it favors valve-sparing. In all of these, valve-sparing had a distinct advantage in terms of lower risk of endocarditis, lower risk of thromboembolism, and lower risk of hemorrhage. Of course, these patients were rarely anticoagulated, so the last is an expected finding. But this, I think, has added more weight to the argument that valve-sparing, if it can be conducted well and a good result achieved in the operating room, is a better operation, not just in terms of quality of life, but in the important metrics of survival, freedom from reintervention, and these three valve or anticoagulate related parameters. This slide is just to make the point that most patients, most children who need an aortic root replacement have connective tissue disorders, and they already have an aortic annulus, which is adult size. So that whether they have a prosthesis or have a valve sparing, it's likely that that prosthesis is large enough to take them to adulthood. These are the size distributions of the valve sparing roots that we did in our pediatric series. And you can see most were 24 millimeters or greater. You know, the average adult aortic annulus diameter is 22 to 23 millimeters. So these were all larger than that. And this picture is just to show how in a valve sparing, the entire aortic root complex fits within the sinus segment of the graft. And this is why it's stable. So in summary, the Bentall and valve sparing operations have similar low operative risk, both in terms of mortality and morbidity. Late survival is also similar, but data are emerging that it may actually be slightly better with valve sparing. Reintervention rates are also similar, but I want to add too that if you have a mechanical Bentall and well-managed anticoagulation, those patients do have very low reintervention rates, and in some series less than valve sparing. Valve sparings do have lower rates of bleeding, thromboembolism, and endocarditis. And finally, for most of the young patients having valve sparing, potential growth of the aortic valve is not possible after a valve sparing, but these patients are already having an adult-sized aortic valve. So the issue of growth is rarely a concern in these patients. Thank you very much.
Thank you very much, Duke, for a nice talk. There's one question for the moment in the chat, which asks that for those programs that only do few cases of aortic surgery per year, which lesions are the best to start with when you want to do a valve sparing surgery?
That's a very, very good question. Well, I would say, first of all, older patients, they have thicker aortas. They don't need an operation that's going to last as long. And those where the valve is competent and you only need to preserve the geometry of the valve rather than to correct it. This was a point that Luca made in his talk. And I love a valve sparing operation when the valve is working perfectly. We choose the graft size based on the Valsalva graft. We add 3 or 4 millimeters to that diameter to get the graft, since the graft sits outside the valve. And then what the beauty of the Valsalva graft too, I think, is that positioning the top of the commissures at the sinotubular ridge of the graft, that almost always is the correct height. And if you do get one of those rare patients with a very tall commissure, you can fix it you can put it above the STJ. There's no reason you can't. But the Valsalva graft has just the right proportions for the vast majority of patients.
Okay, another question. Would you consider Bentall in children?
Yes, and we've done quite a few of them, usually because it's a young patient, more like a late adolescent patient, where the valve is so highly fenestrated that I have no confidence in the ability of that valve to hold up over time. So it becomes a question then, if the patient does not want anticoagulation, which will last longer, a preserved and repaired valve with multiple fenestrations versus a bioprosthesis. And since they are large bioprostheses in most of these patients, I think a valve-in-valve will be a reasonable option. So now we may be getting out to 25 or 30 years without anticoagulation and only one operation.
Okay, would the anatomy of the valve, bicuspid or tricuspid, change your opinion or change your decision to perform a valve sparing procedure in children?
If the leaflets of the bicuspid valve are normal, I mean, the thin, pliable, it's a 180 valve, no calcium. I think bicuspid is a very good operation. I think they're easier than the tri-leaflet ones. But I don't think they're going to hold up as well as a perfect tri-leaflet repair, because it's still an abnormal valve. They rarely work a lifetime without any problems at all. But the problems, I think, are when the bicuspid valve is not 180, and it's very thickened and there's some early calcium. That becomes a tougher call, how hard you work to try to preserve that valve.
Coming back to the Bentall, somebody asks if the redo operation is not going to be too risky. But you suggested to do sometimes valve-in-valve, but of course you may do a reoperation as well.
That's right. It is. We will see how the valve-in-valve effort works out, but I agree, and I think there are, as you know, there are ways to sew the bioprosthesis into the graft so that you do not need to do a redo root replacement at the next operation. You can just cut a couple stitches, pull the bioprosthesis out, and sew a new one inside. That is a low-risk operation. A redo root is not a low-risk operation.
No, that's for sure. Okay, I have no more questions for you. Then maybe you, Duke, you can announce the next speaker.
Yes, so our last speaker is James Black from Baltimore, Maryland. He will be speaking on the role of endovascular therapy in patients with diseases of the aorta.
Great. I'm going to share my screen here. Tell me if you can see the slide view, not the presenter view. Is that right?
Yeah, it's perfect. Thank you.
Great. Well, thanks for the invitation, and speaking on the subject of endovascular grafts. This is something that remains controversial and was a source of great debate on the upcoming AHA aorta guidelines, which should be coming around in the fall of this year. Coming from Hopkins, we always sort of like to start with our forebears. Here's Sir William Osler, who said once, there's no disease more conducive to clinical humility than aneurysm of the aorta. Indeed, that's a great quote, but I like this one even better, which is the tragedies of life are largely arterial. And that is certainly the case when you're talking about patients with connective tissue disorders. These are very difficult diseases, the patients in the prime of their life. And this is a good example of that. It's a Loeys-Dietz syndrome, I believe, speaking to the subject of Shaine and Hal's with the mutation that predicts type B dissections and mortality in the teens. And this is not a piece of aorta that I cut. when I was opening the aorta. This is actually how the intima and media looked in a type B dissection when I opened this thoracoabdominal aneurysm that developed rapidly 1 month after the type B dissection. Here's the extensive aortic reconstruction. That might be my hands, but at one point it was certainly Luca's hands in there. We worked as a team to try and save this young patient. But really what we've come to at this point is a realization that we have a modern problem. The advances in valve-sparing root replacement, management of the proximal aorta have let patients with Marphan syndrome and other connective tissue disorders live a much longer life. So we're seeing aneurysms develop downstream that are actually fairly unique. This is a 60-year-old man, 17 years after his Bentall. He's not a smoker and has this juxtarenal abdominal aortic aneurysm. And what's curious about this CT scan isn't so much the aneurysm, but I mean, look at those iliac vessels. Circumferential calcification in a non-smoker, 60 years of age, is really uncommon. That's an eggshell aorta. Clamping that would be super difficult and certainly could be a problem for your anastomosis. This is another one, 52-year-old man, 15 years after the Bentall, 5 years after his thoracoabdominal aneurysm repair in Houston, came to see me with this aneurysm just distal to the repair. Again, the same story, very calcified iliac vessels, evidence of accelerated early arteriosclerosis is ultimately what we see. And really, I think these cases open the door for the notion of managing connective tissue disorders. And why would that be? Well, of course, we know that these revision type of operations are very difficult. You're usually dealing with reoperative fields. There's a lot of mortality, a lot of morbidity. And fenestrated and branched stent grafts have been applied to degenerative aneurysms, but not really so much to recurrent aneurysms. And certainly most connective tissue disorders were actually an exclusion for the pivotal trials or for the trials on these types of branched endovascular devices. So this is a patient I saw. He had a prior thoracoabdominal repair, and you can see here the what I'll call the junior varsity mistake of leaving the left renal artery button in addition to the visceral inclusion patch. That's just too much aorta, and you can see how this all blew out in a recurrent aneurysm. So we went in through the aneurysm, pre-cannulated the target vessels, and you can see here an endovascular stent graft that I placed. This is now out to 4 years. Of course, the stent graft itself is sitting in surgical graft, proximally and distally. And the stent grafts that are going to the renal vessels and the visceral vessels are, of course, sitting in at least what we would believe would be normal biologic vessels. That is, the medium-sized vessels are not a target of degeneration in Marphan syndrome. But what about the bigger question, the type B dissection? So we've thought for a long time that there was a biological basis for type B dissection. And indeed, the vascular smooth muscle cells that traffic to the cardiac neural crest are also present at the isthmus, so the very distal aspect of the aortic arch. And the time to onset for type B dissection after elective aortic root aneurysm surgery in the Marphan population, one study was an average of around 14 years. But if the index intervention on the Marphan patient was a type A dissection, you can see the distal aorta unraveled at a much quicker pace. Their operation for their descending thoracic aorta was no longer 14 years, it was now down to 2.5 years. A dramatic change in the natural history of a patient with Marphan syndrome. We know, of course, from this study in JTCVS that many patients with Marphans will require repair of their descending aorta in their lifetime. So what are our concerns about an endovascular repair in a patient with a connective tissue disorder? And as I mentioned earlier, these disorders were an exclusion of all the devices, exclusion criteria for the testing of all these devices. We worry about the device radial force, the tendency of the devices to straighten, and of course the bare metal stents. The fragility of the aortic wall is also a concern. You can see here a patient who has a bare metal stent that is sitting outside the aortic arch after undergoing an emergent repair. We also worry about retrograde dissection and a failure to control the proximal aorta. Interestingly, in a series out of China and Shanghai, they commented that retrograde type A dissection was actually the most common complication of Marphan patients treated with stent grafts for their type B dissection. This is a study out of Florida from Adam Beck, looking at just 16 patients. You can see high rates of operative mortality for patients with connective tissue disorder treated with endovascular therapy. Many patients required conversion, and all patients who required a second thoracic endovascular repair progress to require eventually open surgery. So where does thoracic endovascular repair really fit into the paradigm for management of dissection or thoracic aortic emergencies, at least for Marphan syndrome, and to a lesser extent for the other conditions? Well, I think the evidence suggests that thoracic endovascular repair may be safe in the short term, but really the device issues are central in these local aortic complications, especially for acute type B dissection. And there's a potential for thoracic endovascular repair to stabilize some of these descending thoracic aortic emergencies. I think the bridge to definitive therapy when someone presents with rupture is important. Just stabilize a patient and get them to live and fight another day. And of course, if you can use a graft-to-graft surgical sealing zone where they have a proximal graft, be it an elephant trunk or a distal graft in the abdominal aorta, and of course, let the patient get to a center where open thoracoabdominal repair has matured good results. And this was the statement of the STS and AATS back in 2012. And I don't think that position will morph greatly as we get into the 2022 AHA aortic guidelines, but time will tell. This is how it looked for a patient that I saw initially treated. You can see here had an ascending procedure with a valve repair, replacement, presented with a descending thoracic aortic aneurysm, was treated with a stent graft at another facility. You can see that there is a bare metal stent aspect that's sitting across the great vessels in the arch. When the patient was seen 1 month postoperatively, there already was a stent graft induced entry tear seen at the distal aspect of the stent graft. That was monitored. He then presented 6 months later with an extensive new dissection inside the pre-existing dissection. You can see here a complete true lumen collapse in panel C. And by the time they come to see me, now they have a triple barrel aorta with stent graft sitting inside it. Since the thoracic aorta around the stent had remodeled, we dealt with the aorta distally. So ultimately, I think for endovascular therapy and connective tissue disorder patients, the multidisciplinary evaluation by the geneticists, the physicians involved, and the surgeons is really key. All of these procedures, I drive down the blood pressure very low, under 90. I use techniques to reduce operative trauma that includes very careful management of vascular clamping, wire placement. And I do think at this point now, stent graft therapy for patients with connective tissue disorder is defined in a fairly unlimited fashion when we have graft-to-graft surgical sealing zones, revision procedures, and then of course, emergency application of technology as a bridge to eventual referral. Thank you very much. And it was a pleasure to hear all these great talks today, and I'm happy to take questions.
Thank you, Dr. Black, for this provocative talk, I should say, because the last word is not said about that yet. For the moment, I have no particular questions in the chat. Does anybody of the other speakers or my co-chair has some questions for Dr. Black? I might have a question. Nowadays, we would often choose in connective tissue diseases to put a normal elephant trunk, so no frozen elephant trunk, because we think that they will follow a open surgical stage. Is this the right thing to do, or should we try to put in frozen elephant trunks when we do arch surgery?
I think the concern about stent grafts or frozen elephant trunks at the time of that surgery still exists. And I guess the answer to the question is really that stent graft induced entry tears don't always have to occur at the proximal aspect where we naturally are worried about retrograde involvement into the arch. In fact, one study looked at them, they were equally spaced between the proximal aspect or the proximal edge of the stent graft and the distal edge of the stent graft. So the notion that the aorta is normal and then we're going to put a stent graft in it, the distal aspect of the stent may be just as injurious as the proximal. And it might just go to the fact that young aortas are very elastic. We've all stood in the operating room and watched the cardiac cycle and how much the aorta changes its position, torque, and spirals. So I think there is a worry about that. I've certainly seen patients both from working with Duke as well as working with Luca who have elephant trunks in the descending thoracic aorta, and there's always a concern about leaving it there and risk for embolism. I really think that that's probably not a concern, that patients can have a graft in their descending aorta and do not require anticoagulation just because an elephant trunk is placed to be used as a what if down the road.
Okay, thank you. Maybe we can repeat, in fact, the previous question, but I think you partially answered it, that once the ascending aorta and the arch have been replaced surgically, is there any role for endovascular therapy in patients with Marphan syndrome and chronic type B or DeBakey 3B aortic dissection? I think you answered that question in a way.
I think in the normal aorta, I think I've kind of answered that. If the aorta was dilated, and there's of course the chronic dissection, particularly the dissection being older and probably the dissection septum being more fibrotic, placing a stent graft to help avert or promote false lumen thrombosis in the thoracic aorta is certainly reasonable. It's just, again, the distal aspect of the stent in a Marphan patient remains a liability. But it's a situation that I have used. I have a couple patients who have type B dissections in between an arch repair and an abdominal repair, or at least a type 4 thoraco-abdominal repair. So the abdominal aorta is essentially replaced beyond the diaphragm. And they've actually done well with the stent graft, bridging those two surgical graft sealing zones. So it's a somewhat uncommon situation, but I do believe the graft-to-graft sealing zones is very reasonable for a Marphan patient.
It seems to me that, sorry, yes, please.
Yes,
please.
It's not common, but an acute type A dissection that's already been, or it's been operated on, the ascending aorta and arch replaced, but you have malperfusion. Is that an appropriate use of a stent graft in a Marphan patient?
Yes, absolutely. I think the mortality concerns about malperfusion, particularly in acute type A dissection, certainly outweighs the theoretical risk of a stent graft-induced entry tear. And in fact, I have a couple Marphan patients who we've not only had to place the stent graft, but just because my impression is that malperfusion is actually more common in Marphan patients than those who have degenerative dissections. They also then have to get the additional, what we call a dissection stent, which is just a bare metal stent without fabric around it to then hold and prop open the true lumen throughout the visceral anal segment of the aorta. So we're placing a stent graft and a bare metal stent to open up the true lumen in a Marphan patient. And again, that goes to the critical nature of alleviating malperfusion in a type A dissection.
Okay, thank you very much, Dr. Black, for the talk and the discussion. And then I suppose we go to the last talk. Duke, you will announce it.
Yes, it's a case presentation. I'm delighted that we have some time left to hear this. This is aortic aneurysm status post the Norwood, Glenn, and Fontan in a young adult, and it will be presented by Dr. Masaki Kodaira, originally from Montreal and now in Tokyo. Dr. Kodaira.
Hi, thank you for giving me this opportunity to present my case. Our case is aortic aneurysm, status post Norwood, Glenn, Fontan, and young adult. I have no disclosures related to my presentation. Our case is a 90-year-old male. The patient's native anatomy is DRP with hyperplastic left ventricle, hyperplastic left ventricle and thriving mitral valve, hyperplastic aortic arch, DRP with large inlet VSD. The aorta is more anterior than the PA. His surgical history starts with the Loeys procedure, which was performed at 12 days after birth. Loeys procedure was performed in fear of future subaortic stenosis. The aortic arch was augmented with a pulmonary homograph patch, which was brought over the proximal main PA. Atrioseptectomy, right modified BT shunt, PDA ligation was performed as well. The patient underwent right bidirectional gland at 8 months after birth. The patient underwent fenestrated extracardiac Fontan at 4 years of age. I'm going to show the echo images. Here is the small left ventricle, and also we have a predominant right ventricle with mildly decreased systolic function. We have a straddling mitral valve with mild MR. We have a large neo-aortic valve with mild AI. Aortic sinus measures 39 millimeters. Aortic ST junction measures 36 millimeters, and proximal ascending aorta measures 44 millimeters. We have mid ascending aorta measuring 47 millimeters and transverse aorta measuring 50.7 millimeters. From these echo findings, we saw that the patient needed further assessment by CT scan. I'm going to show the CT images from below. As we go up, we see the extracardiac Fontan, and we start to see here the aortic root, which is dilated and which also have an ascending aorta dilatation over here and aortic arch dilatation here. Here are the CT diameters. Sinus above, Baltimore measured 44 over 39. Largest ascending diameter was 67 over 59. Area of 3,229 millimeters square. Arch proximal to the left subclavian artery measures 51 over 45 millimeters. Here is a 3D reconstruction showing the ascending out of the aneurysm measuring 67 millimeters. There have been 5 case reports on aortic aneurysm after Norwood procedure. In these 2 cases, the patient underwent ascending aorta replacement, and in these 2 cases, the patient required Bentall procedure. In the last case, the patient unfortunately had aortic dissection and had cardiac arrest during MRI, and the patient passed away. This is an image taken from the second case in which we have a 7-centimeter aortic aneurysm compressing the left PA. And this is an image from the third case report in which we have a humongous aortic aneurysm measuring 17 centimeters compressing the main stem bronchi and the left atrium over here. This is a study from the Children's Hospital of Philadelphia reporting aortic diameters in 53 patients after Norwood procedure between 1984 and 1994. Although the most profound abnormal growth was seen in the neo-aortic root over here, the neo-aortic valve aneurysm and the ST junction followed a similar trend of dilatation with age. The median Z score for aortic valve aneurysm was 2.8, and the neo-aortic root, it was a Z score of 4.7, and for the ST junction, it showed a Z score of 2.3. Here's the case summary and discussion. We have a 90-year-old male patient with DRP with hypoplastic left ventricle arch and straddling mitral valve who had Norwood Fontan, who now has dilated ascending arch measuring 67 millimeters at maximum. After Norwood procedure, the pulmonary artery valve functions as a systemic similar valve or neo-aortic valve. It is exposed to higher shear forces and stress, and this is supported by systemic blood flow and vascular resistance. And this is considered to be the main reason for ascending aorta dilatation. Ischemia from disruption of the vaso-vagal flow after main arch pulmonary artery transection during the Norwood procedure has been associated with the development of medial necrosis of the arterial wall, which has been associated with medium necrosis, which could lead to development of aortic dilatation. Surgical repair of this patient would necessitate circulatory arrest, which would put this patient with Montreal circulation at substantial operative risk and post-operative risk as well. We would like advice from the audience on how to operate this patient and how to manage this patient after operation. Thank you for your attention.
Thank you, Dr. Kodaira. Maybe we can start with the members of the faculty. Before we can discover your own treatment, Dr. Kodaira. Anybody who wants to kick off?
Catherine, can I make a few comments, Dr. Chervankov?
Sure, of course.
So this is my patient. I did the Norwood, the Glen and the Fontan. This patient has very nice Fontan physiology. And the parents very much would like to know what is the risk of rupture or dissection, because that's what we're really trying to prevent in a patient that half of the aortic arch is really the pulmonary homograph patch, which becomes like leather, and the other half is really the native aorta and the junction with the previous pulmonary arterial proximal end. What would be the risk of a neurological complication? Because obviously there probably will be a period of circulatory arrest. And so these are really the questions. This is the first patient like that I really have to face this decision in my 36-year practice of doing the Norwood procedure. So we need some guidelines and some opinions as to how to proceed. This patient has not been operated yet. It's completely asymptomatic. One thing I would like to ask Massa, who was our adult congenital cardiology fellow in Montreal, is this patient hypertensive, Massa, right now?
No, he's not hypertensive. He's normal.
Massa, I missed this. You have aortic regurgitation. And what's your absolute diameter?
As I showed, we have mild AI, just mild regurgitation. And
you know, in terms of risk stratification, Crystal, you know, there are now reported cases, but they're kind of, you know, far and few in between, of aortic rupture or dissection in patients after the Norwood procedure. The largest series of these patients is actually Christian Pizarro's series, which I think is under 20 cases, and he operated at slightly smaller diameters, maximal diameters. So I think incremental growth and associated, you know, pulmonary valve regurgitations are the things that would push me to the operating room. Also, importantly, some of these patients will actually have connective tissue disorders. In Christian's series, I think 4 out of 17 patients actually were found to have on genetic tested connective tissue disorder.
Unfortunately, we don't have any imaging, I believe, in the last 10 years, Massa, so we don't know what the rate of increase of this aneurysm is.
we haven't done any CT or MRI. This is the only CT we have.
Christo, I would vote for operating. I think you can mitigate the risk of neurologic injury by selective cerebral perfusion.
Yes.
The things that would give me the biggest pause are whether or not he's a bad Fontan at this stage with liver disease or renal disease, which I think you said he probably doesn't have. But that to me would make operation very, very unattractive. But I agree, you know, you don't know how the pulmonary homograft is going to behave or how that little strip of aorta is going to behave, but the wall tension is still going to be really high. And I think his outlook without surgery is not good.
What kind of mortality would you quote the parents in risk of stroke?
Oh, well, I think stroke, if it's selective cerebral perfusion, is less than 5%.
Yeah. And in terms of mortality, Duke, obviously in your hands, mortality would be, I'm sure, lower than in my hands. But anyways, what would you say? It's still a Fontan physiology.
It's still a Fontan, and that's the part that concerns me. But it's weighing risk of spontaneous dissection, and you certainly don't want to do this case in the setting of an acute dissection. But the risk of dissection, I think, in the next few years is 50%, and I think his operative mortality is probably 10 to 20. It's obviously a guess.
Well, I hope at the future webinar, maybe we'll give you some follow-up after discussion with the parents.
Very good. Any other questions?
No, there are no other questions in the chat.
Great.
Some suggestions, but everybody can read them about what they would do with the case.
Great. So I will move on to concluding remarks. I want to thank all of our esteemed colleagues for sharing their expertise with us today, and to all of you for joining us. This has been the 18th in our series of monthly webinars on congenital heart surgery from the World University. Please join us for the next webinar, which will be Aortic Part 2 on July 23rd. And I want to remind everyone that this webinar was recorded and will be available on the World University website. Christo.
So thank you, everybody. This was a really fantastic webinar. I would like to thank our co-chairs, and we're sorry that Dr. Nilva could not join us today. I would like to invite you all to consider coming to Marrakesh for the first face-to-face meeting of the World Society in the last 2.5, 3 years. So we're anxious to all meet in Marrakesh. This will be the 7th meeting of the World Society for Pediatric and Congenital Heart Surgery, a joint meeting with the first meeting of the newly established African Society for Pediatric Congenital Heart Surgery. You can see the website, marrakesh222.wspchss.org. And the main theme of the meeting is tetralogy of Fallot and rheumatic heart disease. So I hope to see some of you at this great meeting in Marrakesh that is planned for June 15th to the 19th, 2022. Thank you very much. It has been a great webinar, and have a nice day.
Thank you. Bye.